Basically, no financial disclosures. So when you look at chemical injury, the most commonest questions that are asked is, will medical management suffice? Whether amniotic membrane alone would be sufficient? What to do if the amniotic membrane disintegrates? How do you manage a severe grade injury? And to understand all that, we need to understand what is the effect of the chemical burn on the eye, and we need to grade the severity of the injury before we are able to answer any of these questions. So with that, Dua did give us a classification where he said, okay, you look at the limbal extent of the damage, and you also look at the conjunctival extent of the damage, because ultimately you need some epithelium to cover the ocular surface. And he's graded from the initial Rupert Hall, he's kind of made the grade 4 Rupert Hall into 4, 5, 6 as Dua's classification, saying that not all grade 4 of Rupert Hall behaved in a similar manner. So it was one step forward. The important point here is he did not use the word limbal ischemia. He used the word limbal defect or limbal involvement, because we cannot really quantify the extent of limbal stem cell loss during the acute injury. But when you look at even Dua's classification, both pictures that are there on the side are actually a grade 6. Forget the annotations in between. I'll come to that later on. Both are significant conjunctival defects, significant limbal defects. Both are grade 6 injuries. Both behave differently in a sense. One required a keratoprosthesis. Another one was we were able to salvage with stem cell based therapy. So this is important that even with grade 6 duas, there is a difference in outcome. So we need to understand the effects. And with that in mind, we said that yes, what are the factors of chemical injury that affect us? It involves the inciting agent, it involves the inflammation, it involves the amount of epithelial defect, it involves whether there is ischemia or not, it involves whether there's exposure, and it involves whether there's any change in the intraocular pressure. All these are direct effects of the chemical on the ocular surface, and you need to address each one of them for you to get a good outcome. And this is what we published as the I's and E's in management in ocular surface. We also get then came out with a classification in terms of a grading system which we published in IGO, where we tried to grade the severity of each of them and try to say that you probably need to address all these factors when you are addressing chemical injury. So chemical injury, obviously the most important thing is you would probably take a medical legal consent. You will wash the surface with whatever is available. You don't have to really wait for something specific. Any RL which is available, or any solution which is available, you can use to wash it. The acute stage management will involve medical measures with respect to topical steroids, cycloplegics, anti-glaucoma medications, topical ascorbate or citrate, and systemic Diamox if the pressure is high, and systemic steroids if the pressure is low. And obviously, you have the surgical management if the injury is severe. So let's go through one by one. So when you're looking at an epithelial defect, if it's only limited to the cornea, you might just get away with a bandage lens. A slightly larger defect, you might want to consider an amniotic membrane. But if it's a significant defect, more than grade 4 of duas, you would probably need what we call as alloslet, where in addition to the amniotic, we take limbal bits from cadaveric tissue and put it, because we need to give some source of epithelium for the surface to epithelialize, because it takes longer for the conjunctiva, which is also denuded, to kind of cover the surface. Because in the acute stage, faster the corneal surface epithelializes, the less problems you would have with respect to scarring, melting, and further visual rehabilitation in the future. So this is what we published, where we said that the outcomes of alloslet in acute chemical injury scores over just a plain amniotic membrane in a similar grade 4 to grade 6 to us classification. And this is some photos from our publication, where a patient with a grade 6 burn with a lime plaque stuck on the surface underwent a lime plaque excision, lamellar graft, amniotic membrane with an alloslet, and subsequently 6 months later underwent an autoslet, and is maintaining 6/9 vision over an 8-year period. But again, defect is not just one parameter that we are assessing, like in Dua's classification. When you look at both these pictures, one eye is red, the other eye is white. In a chemical injury, if you see a white eye, it is a very, very, very poor prognosis sign. That means all the vascular tissue on the ocular surface has got denuded. The outcome of an eye which has absolutely no vasculature and an outcome of an eye which has vasculature is completely different. And this is what Rime postulated in 1997, where he introduced the concept of tenonplasty, where we need to mobilize vascular tenons from the periphery and suture it. And this is just a small video showing it, where we are debriding the necrotic tissue, trying to go to deeper to the fornix. You would cut the tissue till it bleeds, mobilize the vascular tenons, secure it closer to the limbus. Then you can drape the surface with an amniotic membrane. This allows suture it, because you want to anchor it there, otherwise it will tend to retract. You might take more sutures, then you place the amniotic membrane. Since the tarsal surface was also raw, we placed the amniotic, we placed a conformer, reflected the surface, surface, sutured it, put the alloslit bits, and then did a tarsorrhaphy. So with this in mind, we thought we should probably get something which is available for every ophthalmologist to look at. And unless they know that these are the parameters that they need to look to, you might miss it. So we kind of come out with something called as a code score, where we basically divide the conjunctival involvement from 0 to 4 based on 25%, 50%, 75%, or 100% involvement. O stands for the limbus and the scleral ischemia. Limbus grading is based on the Duhas classification. Scleral ischemia 25, 40, 25, 50, 75, and 100% involvement. Physical tension, whether it is normal, low, or high, and exposure, whether there is no exposure, mild, moderate, or severe exposure. This is freely available in our website. You can open it up. And basically, like I said, the limbal involvement is based on Duas. Conjunctival involvement is on a 25% scale. The ischemia is on a 25% scale, and the exposure is mild, moderate, and severe. Why it is important is because it gives you the starting point. What is the number that you're starting off with? And your end point has to be code zero. Your end point has to be when all parameters come down to zero. So illustration, this patient presented with a bilateral severe chemical injury grade 6. So if you look at the conjunctival involvement, it is 100%. You look at the limbal involvement, it is 6. You look at the ischemia, it is 4. If you look at the pressure, it was the exposure, it was there was exposure. So what did we do? For the defect, we did an amniotic. For the deficiency of the limbal cells, we did an alloslet. For the ischemia, we did tendinoplasty. For the exposure, we did a skin graft. For pressure, we gave systemic steroids, but the pressure was not building up. The axial length was reducing from 16 to 14. We didn't have a choice. We went ahead, did a lens aspiration, vitrectomy, put in oil because we wanted to salvage the eye. We were able to salvage one eye. Subsequently, that eye underwent a type 2 Boston keratoprosthesis, and the patient is maintaining 636 N18 vision 6 years post the intervention. This just come recently, but 5 years post-op, which is maintaining 636 vision. So this it's actually very easy to enter, because apart from the parameters, it's also important to know what is the time frame of the injury. Say 1 presentation and a 1 month presentation means differently, because if at 1 month it is grade 6, it means the injury was much worse to begin with. Similarly, whether it is unilateral or bilateral, it is important, because ultimately the visual rehabilitation in the chronic phase depends on how severe the other eye is, because whether you would go the stem cell based way or you would go the keratoprosthesis way would depend on the laterality. So once you enter the data, it all comes under a drop down menu. You can get a timed, dated, and you can even upload your image and have it in your EMR, and it gives you a definite answer that yes, you are at a grade of disease which needs to be improved further based on the assessment. So it kind of gives you a score which you need to always try to get towards zero. So till you reach code zero, you have to keep intervening, or at least keep the patient in close follow up. So to conclude, decode the effects of the burn on the ocular surface, address all direct and indirect effects of the burn on the ocular surface. Aim is to reach code zero, which basically means the end of the procedure, you have to have an epithelialized surface. You have to control the intraocular pressure. There should be no exposure of the ocular surface. You want the eye to live so that you can fight another day and give vision to the patient. For better long-term outcomes, good acute care management is essential. Thank you.